oral medications that is now released by IV painkillers. And the patient will be with chronic mesenteric ischemia. There will be that more food fear, and patient would have a more cachic state, a longer duration of weight loss, or those symptoms might also be there along with it.
Why is she bending forwards when the pain occurs? Why do you think she bends forwards?
Sir, pancreas being a retroperitoneal organ, the inflammatory pathology might, the patient might get a sensation of relief on bending forwards. The impingement on the spine or back nervous system can be, it will be less on bending forwards.
In how many cases this presentation is, you get this classical description of pancreatitis? Is it a absolute thing or is it a relative thing?
Sir, radiating to back feature, sir?
Yeah, radiating to back, bending forwards.
Sir,
can it happen in other conditions also?
Sir, it is not always present in pancreatitis, but it is classically described as a pancreatic pain when patient pain relieved on bending forwards.
Biju sir wants to add anything.
When you make summary, it is better to avoid diagnostic words. Like you mentioned pancreatic type pain.
Okay.
When you put a diagnosis, better not to use probable diagnosis. Okay, this is a sensitivity approach what we follow in case history and presentation. So that means you have to include, it is an inclusive diagnosis. Okay, you have to include mesenteric ischemia, peptic ulcer disease, and other neoplasms also can present. You know that several neoplasms in pancreas can have a long history and have a recent worsening now. So when you put only chronic pancreatitis, then your diagnostic thought process may come into question. Okay. So that is not the correct way, especially in a lady 52-year-old with no epidemiological data supporting that. Okay. So
okay.
I think you can proceed with
any cystic neoplasm of pancreas in this case? A 52-year-old lady.
The cystic neoplasm of pancreas.
7 years, gradually expanding in size, causing pain, impinging on retroperitoneum, and now leading to weight loss.
It is a possibility, sir. Cystic neoplasm of pancreas.
All these
but
possibilities.
it is.
These are the possibilities you need to keep after history. After history, you cannot stick on one diagnosis, chronic pancreatitis, and without any adjectives. So after history, you should make a habit to see what all other organs are nearby which can cause these problems. So apart from chronic pancreatitis, gastric ulcer, chronic mesenteric ischemia, cystic neoplasm in a 50-year-old lady are the possibility which you should keep in your differential diagnosis, at least after history.
Okay.
You please proceed.
Yeah, please proceed.
General physical examination, patient is conscious, oriented, moderately built and nourished. He has a ECOG score of 0. BMI is 19.5 kg, weight of 50 kg, and height of 160 centimeter. Breath holding time is 31 seconds. She is afebrile, pulse rate of 79 per minute, BP 120/70, respiratory rate is 17 per minute. There is no pallor, icterus, cyanosis, clubbing, or pedal edema. There is no generalized lymphadenopathy. There is no signs of dehydration or malnutrition. Abdomen is scaphoid with umbilicus central in position and inverted. There is no fullness or visible lump. All quadrants of abdomen move equally with respiration. No scars, visible peristalsis, skin nodules, or engorged veins. Hernial orifices, no visible cough impulse. No renal angle fullness. On palpation, abdomen is soft, non-tender. Liver and spleen are not palpable. No any other palpable lump. Hernial sites, no palpable impulse. On percussion, liver dullness is felt at the upper border of 15 intercostal space, and liver span along the right midclavicular line is 14 centimeter. Flanks are tympanic. Auscultation, normal bowel sounds here. No bruit or venous sum. Digital rectal examination, perianal skin is normal. Normal sphincter tone. Gloves stained with yellow stools. Other system examination, respiratory system, normal vesicular breath sounds here. Bilateral air entry equal. No crepitations or other added sounds. CVS S1, S2 normal. No murmurs. Central nervous system, higher mental functions normal. No focal neurological deficits. To summarize, the physical examination is not contributory. 52-year-old female, known diabetic with history of recurrent episodes of upper abdominal pain lasting for 7 years with progressive worsening of pain over the last 2 years requiring injectable painkillers with history of recent admission for acute exacerbation with recent history of significant weight loss and recent worsening of diabetes. The differential diagnosis would be chronic pancreatitis with suspicion of underlying malignancy with endocrine insufficiency without exocrine insufficiency. Other differential diagnosis might be chronic mesenteric ischemia or pancreatic cystic neoplasm progressing into malignancy.
Why are you telling the physical examination is not contributory? Are you looking for only positive signs?
Sir, no, sir, negative signs might also be.
What you wanted to look in physical examination based upon our corrected differential diagnosis. We told you 4 or 5 possibilities. Based upon that,
Yes,
what you wanted to look, which is not there and which may affect your list of differential diagnosis.
Sir, for chronic pancreatitis, if the suspicion of malignancy, there can be an associated icterus, obstructive
it is
jaundice
not there. It
features.
is not a contributory
It is not there.
diagnosis. It is not a contributory finding. Absence of jaundice.
Absence of jaundice, non-palpable gallbladder.
Yes. What else?
There can be signs of severe cachexia, malnutrition. BMI is 19.6. It is not very low, but it's on the lower side of normal.
So 3 points next. What other things you are looking for?
Sir, if it is a large lesion, sometimes it might be palpable in a thin patient.
So absence of palpable mass, what else?
And sometimes patients of pancreatitis due to complication of portal hypertension can have a splenomegaly that might be palpable.
Okay,
or local complication of chronic pancreatitis, pseudocyst, or any collection that can have a lump, or with the malignant transformation history, there might be ascites, free fluid in the abdomen. It can be in pancreatic ascites also, or it can be secondary to a malignant transformation causing ascites also. That is not there.
All these things you have to tell. Don't put a blanket statement that physical examination is non-contributory. Okay, even in mesenteric ischemia, sorry, mesenteric, let us say SMV syndrome or mesenteric ischemia, all these things you get a lot of findings. Okay.
Okay.
So now you know that physical examination you look for some findings which was not there. Now,
not there.
How it contributed to your diagnosis which you summarized?
Sir, for history suggestive of chronic pancreatitis with complications of pancreatitis are not present in as per the examination findings, like any pseudocyst or portal hypertension causing splenomegaly. So that contributed to this thing. Other than that, for a gastric ulcer, which can progress into malignancy or impinging on the retroperitoneal structures, there is no classical distension in the upper abdomen or visible gastric peristalsis.
Dr. Vaibhav and Dr. Anand, please contribute here.
Yeah, I actually see the again and again the same point is coming. No, contributory factors here. We need inclusive of all differential diagnosis in this case. A gastric ulcer, posteriorly placed gastric ulcer, boring into the pancreas can have the same finding without the gastric outlet obstruction. So they will also sit forward when they eat, they will have that pain, so they will sit forward. All those things, benign ulcer changing into malignancy, involving the posterior wall of the stomach, boring into the pancreas. So that is one differential diagnosis. So fortunately, this case doesn't have any palpable lump. Okay, suppose the same patient had a lump, then our discussion even stretches further. Suppose you find a lump in the epigastrium. How will you describe the lump?
Sir,
what does that mean to you? Suppose you examined the abdomen, you find a tender epigastric lump. What are all the things that will run in your mind?
sir, I would look for the surface of the lump, whether it is smooth or irregular, whether it is soft or firm. It is tender or non-tender. If it is tender, then I would think more in terms of complications of pancreatitis causing the lump, like an pseudocyst or infected collection or necrosis, Oldorf necrosis, that can cause a tender lump in the upper in the epigastric region. If it is the lump is not smooth, it is irregular, firm in consistency, then that might be suspicious of
Yes.
malignancy.
Yeah, to put it in a nutshell, when there is an epigastric lump, you have to think of an inflammatory mass. Either it is a chronic inflammation or it is an acute on chronic pancreatitis, which is causing, as you said, Waldorf necrosis or so. Then a cystic neoplasm can also produce a lump. So these things should run into your mind when you find a lump in the, of course, malignancy on a chronic pancreatitis. So these things you should bring into the diagnosis, especially a lady of this age, middle-aged women. Cystic neoplasm comes into the picture. Please don't forget about it.
Okay.
Can we allow him to proceed now?
Yes. Please proceed.
Now,
what do you want to do next?
Sir, there is a recent admission 1 month ago with history suggesting of imaging. I would like to first look at the records of the patient if it is available to me.
What record you want? You please tell what you want.
Sir, the discharge summary or the imaging findings that was done, ultrasound or what was done at the time of admission.
No, which imaging finding you want?
Ultrasound whole abdomen findings.
You want to see the ultrasound of them. Can we have the ultrasound here?
Ultrasound shows.
Read it and make your impression and then tell us.
Yes, sir. Sir, ultrasound shows features of chronic calcific pancreatitis with dilated MPD of 10 mm dilated and intraductal calculi, largest 18 into 6 mm, with features suggestive of peripancreatic inflammatory changes in the form of bulky and irregular contour of the head and peripancreatic edema, with a collection of 4.5 into 2.6.
Don't describe what you are seeing there. Just tell your inference.
Yes.
You already told the findings.
What is this ultrasound is suggestive of an acute on chronic calcific pancreatitis with collection in the head and uncinate of the pancreas with distal CBD narrowing, likely inflammatory narrowing with dilated CBD and IHBRD, with no evidence of ascites or any lymphadenopathy. With another positive finding of food and fluid residue in the stomach, suggestive of maybe chronic calcific pancreatitis causing inflammatory narrowing of the gastric outlet obstruction features may be partial.
No, rather than describing,
Sir.
you please tell your diagnostic words. Chronic pancreatitis is there?
Sir, acute, yes, sir.
It is there. Acute on chronic pancreatitis is there?
Yes, sir.
You think
There is
it is there?
peripancreatic, sir, peripancreatic edema is there.
Okay, two terms. What else is there?
Sir, parenchymal echo texture is altered and bulky in size. The head of the pancreas and tail of pancreas is bulky with irregular contour.
No. What is your diagnostic word? You told pancreatitis.
Sir, acute on
pancreatitis.
chronic, sir, acute on chronic calcific pancreatitis with peripancreatic collection.
It is not peripancreatic collection. It is within
Pancreatic,
the head.
sir, pancreatic parenchymal collection. Yes,
So
sir,
what is the word for that?
collection.
When you get collection in this situation, what is the word?
Sir, it can be a pseudocyst or a walled-off necrosis, sir. Since it is an for that I need the timing of the acute attack.
And what else is there? So you have to complete your
Sir.
diagnosis at this stage.
Yes, sir.
You got
yes,
the
sir.
ultrasound for a diagnosis. So please complete the diagnosis with the apt words.
Sir, acute on chronic pancreatitis with pancreatic collection with distal CBD stricture, inflammatory stricture of the pancreas with features of gastric outlet obstruction.
Okay, so what type of collection is that, according to you?
Sir,
No, I am simply saying that this is an acute on chronic pancreatitis. That's all. I can explain everything with that. Do you have objection?
no, sir. It can be explained everything the acute on chronic pancreatitis.
How you'll explain bile duct stricture? Biliary dilatation.
Sir, inflammatory changes in acute on chronic pancreatitis, recurrent acute or acute on chronic pancreatitis can cause narrowing of the distal CBD due to inflammatory edema or inflammatory stricture, fibrotic changes there that can explain the distal CBD narrowing.
But do you think that this patient has a fibrotic stricture according to history and examination? That is what we are seeing here, likely. What else can cause this dilatation?
Sir, the collection in the head and uncinate can also cause a mass effect on the CBD, distal node CBD.
But in this collection, do you have any subtle evidence in the ultrasound that this collection is large enough for location-wise critical to cause this mass effect?
Sir, it is in the head and uncinate and it is causing mass effect on the splenoportal confluence also. So both these are suggestive of causing a mass effect on the distal CBD also.
Okay, Dr. Vaibhav and Dr. Anand, please contribute here.
Yeah. So what do you want to do next? What is your next thing will come in your mind after this thing? It's acute and chronic pancreatitis. So what
sir, I would like to have blood investigations, hemogram, complete count, CRP levels, amylase lipase levels, HbA1c for sugar, RBS, and renal function test, serum electrolyte, liver function test to look for.
You want all this for diagnosis? What you want to?
Why you need CRP, Procal?
Not procalcitonin, CRP and amylase lipase.
What is the amylase level you were expecting in this case?
Sir, currently patient is as such asymptomatic. The ultrasound is suggestive of peripancreatic edema and bulky pancreas.
Mm-hmm.
I would like to know the inflammation, whether it is ongoing currently or it's there or not. So that's it.
The amylase level will tell you.
Amylase and lipase, yes.
Okay,
And CRP levels also.
Yeah, Dr. Karthi, and the CRP I am giving, hypothetically it is 180, you keep it. Then amylase lipase is normal. Only CRP elevation is there. And now you have an ultrasound report like this. What will you do for the patients?
Sir, CRP of 180 and amylase lipase levels
Yeah.
are normal with this ultrasound finding.
Yes. You have a clear-cut ultrasound finding in front of you with all these features.
Yes, sir.
Elevated CRP, all other reports are normal. How will you manage this patient?
Sir, I would like to proceed with CECT, sir, pancreatic protocol CECT.
Okay, the CT also gives the same picture what the ultrasound has given. There is no other contributory findings in the CT.
Okay.
What will you do now?
Sir, the mass in the head and uncinate process of the pancreas is still inconclusive on CT also, is what you are telling, sir. Like,
No, it is a
the-
collection. Same thing they are giving. It is a collection.
it is a collection. Sir, it will be, I would look for any features of, currently history-wise patient doesn't have any features suggestive of cholangitis. So I would conservatively manage this patient for now if CT is showing a collection, clear-cut collection, rather than CT is not suggesting any other mass lesion, but only a collection in the head of pancreas. Then the management would be now currently to manage the pain conservatively, and then the pain is significant as per the history, and it has progressed to the level of requiring IV analgesics. So once the there is ongoing inflammation as per the ultrasound and CT. So after the inflammation episode settles, surgical management would be planned, sir. Right now, it will be conservative management.
So your intention is to treat it as an acute pancreatitis episode.
Yes, sir.
That should be there. Now let us see all the test reports. We can give the results, blood test, CT, everything. You please read the hemogram picture.
Sir, hemoglobin is 12.6, total count is 7,500, platelet is 3.31 lakh. Normal urea is 17, creat is 0.6, sodium, potassium chloride are normal, so 137, 4.098.
You can tell which is normal. Just like just
Okay,
read.
sir. LFT and INR are normal, sir.
Anything
Albumin is also
anything
normal.
specific you would like to see here?
Sir, alkaline phosphatase levels and direct bilirubin levels are normal. 111 alkaline phosphatase. Albumin is also good, 3.9. Bilirubin is also normal, direct and total both.
Your next investigations.
Sir, CRP and HbA1c value for sugar control and amylase lipase level.
Do we have CRP and HbA1c?
No, sir. HbA1c was 7.5, sir.
Okay.
Okay.
Any other thing? Amylase lipase you wanted? So this is
Normal.
35 to 17.
Okay. Okay.
So can
Sir,
a patient with acute or
something-
chronic pancreatitis can have a normal amylase lipase?
It can happen at the end of burnt out gland might not exactly secrete the amylase lipase level, sir. It can be normal in late stages of chronic pancreatitis.
And can they have high amylase lipase level when the acute episode is over?
Yes, sir. Persistent amylase levels can be there in collection pseudocyst. There is a chances of having a persistent hyperamylasemia.
Okay, so his amylase lipase levels are normal, counts are normal, ultrasound showing acute or chronic pancreatitis. So you want to do after this?
Sir, to characterize the collection alone, if it is a collection or a mass lesion, the ultrasound doesn't give a it is isoechoic or what the collection is not. So I would like to go ahead with the CCT pancreatic protocol, CCT abdomen.
Pancreatic protocol CT?
Yes, sir.
What is pancreatic protocol CT scan?
pancreatic protocol CT is multi-director CT with pancreatic phase at 40 to 50 second and portal venous phase at 60 to 70 second. And it is a thin slice CT, minimum 3 mm cut. Ideally, it should be less than 1 mm or 1 mm cuts, and minimum of 64 slice CT.
What is the advantage over routine phases?
Sir, advantage is that this multi-director CT allows for multiplanar reconstruction, and thin slices of cuts will be seen, so that we can have all the
These things are there in other CT scan also. What is the difference?
So the pancreatic phase contrast is not there in other phases. The
This is late
40 to
arterial
50
phase.
second late arterial phase pancreatic phases.
Okay,
That
can we
is
have
not
CT scan?
You want a pancreatic phase CT in this patient?
Sir, it's ideally for evaluating mass lesions of pancreas.
No,
But
question is, do you want it here?
In this case,
yes,
Please
sir.
tell yes or no.
Yes, sir.
Why you want?
why?
Why you want an early arterial phase or late arterial phase?
Late arterial phase.
Why?
Sir, that will
Why you
give
want?
the character. Sir, if the lesion in that is mentioned in the ultrasound, that is a 4x2 centimeter lesion in the ultrasound, the enhancement pattern of that lesion, if I am suspecting a mass lesion, that lesion, then the enhancement pattern of that lesion in the late arterial phase of the pancreatic phase would be giving a much more better evidence of the characterization of the lesion, if it is a malignant mass lesion or not.
Ultrasound told it is a collection, no? Ultrasound told it's likely a collection, no?
So the ultrasound report, they haven't mentioned whether it is a homogeneously isoechoic or
The
there is
message we are trying to tell
heterogeneity.
is very simple. Message we are trying to tell is anything in the pancreas, go for pancreatic protocol is not correct, okay?
Not
This
correct, sir. It's
particular
only
phase
for
is designed for certain particular diagnosis or to rule
yes,
out
sir.
particular diagnosis. Especially in this
Yes, sir.
case, there is inflammation, stones are there. Okay, fine. You wanted to see arterial enhancement in the presence of stones. All these things are a little bit off the mark. Okay, so even otherwise,
Yes, sir.
CT is fine. I think so.
Yes, sir.
Okay, yeah, please proceed. Yeah, you want to see the CT? Please proceed.
Please show the CT scan.
So, like to first see the plane images axial cuts. So. Can I scroll? Sir?
You have control, Sarthik.
Okay. Okay. This is a plain CT axial cut imaging of the abdomen. Lower chat cuts, there is no evidence of any fluid or pleural effusion. I could see
Yeah.
calcific.
Yeah,
Sir,
what do you see in the plain CT? Yeah. Yeah, you can
sir,
stop there. Yeah, you can
yeah,
stop
1
there.
second.
Yeah.
Sir,
Now read.
large, I couldn't measure the size, but the size looks like large calcifications are present inside the main pancreatic duct, and also in the body, in the tail, body, and also in the head and uncinate process. And there is an
Stop there and now read. Just
sir,
above. Just go a little bit above, little above. Yeah, now read. Yeah.
yes, sir. And There is fat stranding, peripancreatic fat stranding is there. Pancreas is atrophied, only the body and tail region, only the duct and calculi are seen with some minimal peripancreatic fat stranding around it. Here in the head region, there appears to be a
How will you describe this thing?
sir, it
On a
can be a
non-contrast
collection. Non-contrast CT, it is ill-defined lesion, sir. I can't characterize much in non-contrast CT this one,
Can
but
you
it is
see?
located in the head and uncinate of the pancreas.
And the
It is,
standing is there in non-contrast. Can you comment upon standing?
sir, the fat planes are a little bit seen in non-contrast, so it's not the ideal face to
So
see, but
you need to see that you have arterial and venous phase. You can comment on that. So no
yes,
need.
sir. In plain face, other than that, no pleural effusion or no ascites is there. Now I would like to go for the pancreatic phase, late arterial phase imaging. Okay. Can I have the control? Yes. Okay.
Yes. Yeah. That is okay.
Yep.
Yeah. Stop there. Now read. Yeah.
So 1 second, sir. Just
Yeah.
Keep talking while you are seeing the CT
Okay.
scan. That is.
Sir, this is a late arterial phase axial cut imaging. Here, the body and tail of the pancreas is atrophic with the dilated main pancreatic duct with multiple intraductal calcifications seen. In the head and uncinate region of the pancreas, I can see an ill-defined hypodense lesion. There is
Characteristic of?
sir, characteristic of an ill-defined hypodense lesion. It can be an inflammatory head mass, characteristic of acute on chronic pancreatitis.
Why it is not a cystic neoplasm? You say some lesion there.
Yes, sir.
Why is it is not a cystic neoplasm?
So there is no well-formed capsule or a wall
Stop,
around it.
please.
It is ill-defined.
Yes. Stop there and now read. Why it is not a cystic neoplasm?
Sir, cystic neoplasm will have a capsule well-defined wall around it. It will be more defined. This is a ill-defined lesion. There are surrounding fat standing around this lesion, and cystic neoplasms might have septations or might not have septations also. But the wall enhancement pattern.
Can this be a serous cystic neoplasm?
Serous cystic neoplasm.
No, say yes or no.
Sir,
if
no,
you say
no, sir.
No, tell 1 point why it is not a serous cystic. Can this be a mucinous cystic?
Sir, serous cystic neoplasm, no. Mucinous cystic neoplasm.
Why no? Why no?
Sir, sir, cystic, it is having ill-defined.
No, it is generally to assess your radiological knowledge about the CT. As a surgeon, we should be well enough than radiologists to tell that it cannot be. We should know the features of a serous cystic neoplasm and a mucineocystic neoplasm, IPMN, all those things we should know radiology. Huh?
Yes, sir.
So what is it you see now? Now you describe. You have an
Sir,
inflammatory mass with
yes, sir.
fat stranding and non-enhancing lesion inner and around the head and uncinate process.
Uncinate processes.
What else you will read apart from that? You have
Sir,
already described about the intraductal calculi. Now what else
yes,
you
sir.
will see?
Sir,
What are the other things you will see?
intraparenchymal calcifications are also seen in the uncinate region and in the head region. Other things are vascular. Yes, sir. Peripancreatic vascular. Portal vein is splenic vein is patent. There is
No,
no
you are seeing which
narrowing
phase.
or thrombosis. Sir, no, this
Yeah.
is a late
Karthik,
arterial phase.
please be very
Late
clear
arterial
about
phase.
one thing. Okay.
Okay, sir.
You
Arterial.
should explain the features you expect in arterial phase. Once you finish it, you go
Then
to
we go.
the next phase.
Yes, sir.
Make
Sorry,
your
sir.
differential diagnosis.
Yes, sir. Yes, sir. In this late arterial phase, arteries, I look for any pseudoaneurysms in the arteries if it is there.
Is it there so that we can move to the
No,
next
sir,
phase?
it is not there.
Move to the next phase.
Okay. I like to see for the portal venous phase.
Yeah, please comment upon this.
Yes. Portal vein is normal, but at one point there is
What do you call
irregularity.
this? What is the collection doing to the portal vein?
So the portal vein is pushed up by the collection, and there is a abutment of the portal vein and ill-defined path planes with the wall, and portal vein after the portal vein splenic vein confluence, there is a narrowing of the superior mesenteric vein.
You say there is a splaying of the portovenous confluence.
Sir, yes, sir. The lesion is having ill-defined path
Yeah,
planes
you
with
stop
the.
there and now you read. What do you find now in this picture?
So there is abutment of the portal veins and splenic vein confluence, splenoportal confluence. There is abutment by the inflammatory head mass, and there is no thrombosis, but there is narrowing distal to this of the superior mesenteric vein.
Okay. Any other compression you can see here?
Sir, I couldn't trace the.
See posteriorly.
Splenic vein is same. Other than that, the compression is.
See, the lesion is predominantly head and the uncinate. So splenic vein.
Sir, it's far away.
Karthik, can you tell what is the exact location of this lesion? Where
Sir,
exactly
it is. So more in the uncinate and less in the head.
Okay, why you are telling so? Explain that point.
Sir, it is going mostly originating after the splenoportal confluence and located more posterior to the superior mesenteric vein. And
so when it is in the head, what happens? When it is in the uncinate process, what happens? Tell the difference.
sir, if it is in the head, there is a chance of abutment or impingement or narrowing of the portal vein. If it is in the uncinate, then there is a chance of involvement of the superior mesenteric vein. With respect to vasculature,
If it is in the head, what will be the location of the portal vein? And if it is the uncinate process, what will be the location of the portal vein and splenic vein? Please explain that and with respect to this patient. Where is the portal vein with respect to the collection?
So,
Collection
here
of lesion,
anteriorly, anteriorly it is there.
Is it more suggestive of head or uncinate process?
More suggestive of uncinate, sir.
Okay, so what is your diagnosis now? Do you want to see any other phase?
Sir, in venous phase, I would also like to look for
Any
the
other finding in the liver?
Any other, any
yes,
other
sir, yes, sir,
finding?
yes, sir. I would also like to
Extrahepatic
look for extrahepatic biliary
biliary
radical, sir,
What
CBD
is happening?
dilatation and IHBRD. I have to. The gallbladder is distended.
Yes. Then what else?
IHBRD, central IHBRD is there. CBD is dilated in the proximal part. In the lower part, CBD is narrowed. Distal narrowing of CBD is there, and minimal central IHBRD is there, and dilated CBD is there, and distended gallbladder is there. And other than that, liver is normal, sir.
And the portal vein is just splayed around the mass, but there is no thrombus seen in the portal vein or in the splenic vein. Huh?
No
there is
thrombus in portal venous splenic. Yes, sir.
Yes, it is just splayed, pushed, gives a compression effect. That's all. Other than
Yes,
which
sir.
there is a distended gallbladder with the narrowing at the lower end of the CBD.
CBD, yes.
So what is your diagnosis now?
So my diagnosis now would be acute on chronic pancreatitis with inflammatory head mass of the pancreas, head and uncinate mass of the pancreas.
So what are the differential diagnoses you are considering at this stage?
Sir, this can be just an inflammatory head mass, or it can be a suspicion for malignancy. But with acute features, it is more of an inflammatory head mass. The other differential would be
Inflammatory head mass and walled off pancreatic necrosis and collections. All these are same or different?
Different, sir. Inflammatory.
Are you considering walled off pancreatic necrosis in this patient?
No, sir. There is no organized wall. It is a ill-defined collection, and there are areas of enhancement and areas of hypodensity in between. It is heterogeneous lesion, especially in the uncinate region.
That is what, when you comment an inflammatory lesion like this, first you say it is an inflammatory collection. Then you bring in the picture of malignancy. Will it be easy to read in the CT when there is a severe inflammation and fat stranding like this?
No, sir. It won't be easy to differentiate with the acute episode. Fat stranding, inflammatory head mass, and malignancy are not clearly discernible.
No, Karthik, why are you telling there is acute episode now? Where is the evidence to show that? Apart from this lesion, where is the evidence to show that there is an acute episode?
Sir, around the lesion, around the head and uncinate process of pancreas, fat stranding is seen. That is the only evidence, sir. Other than that, there is
Body and tail, is there any evidence?
No, sir. Only in head and
Can
uncinate
you
region.
explain all these symptoms, signs, and laboratory finding based upon this collection or lesion?
This based on laboratory evidence, everything, then it is a inflammatory head mass. Sir. There is no acute features are not there. If we correlate everything with the clinical history and examination finding of no tenderness, clinically patient is asymptomatic currently. With this current CT finding would be a chronic pancreatitis with an inflammatory head mass.
Why are you telling? Can you please specify why you are not considering malignancy or putting it as a least probability, less probable? Are you still considering it?
Sir, still considering, but currently less likely, sir.
Why less likely?
Sir, with this inflammatory changes, it is difficult to say currently. But But as per the CT evidence, history-wise, I would say there is evidence of malignant transformation in the form of recent worsening of diabetes and recent weight loss.
Yes.
CT, but there is no obstructive jaundice. It is more of uncinate, so that might explain that. But
Okay.
likely to have obstructive jaundice also, but there is no obstructive jaundice pattern here.
Okay.
The other negative point for not having a malignancy is loss of appetite is not there. Only loss of weight is there. These two are negative points. In imaging finding, the hypodense lesion more located in the uncinate is heterogeneously enhancing, sir, with more of inflammatory changes with pockets of head
Can
and
you do
uncinate
any
fat
other,
stranding. Around the head and uncinate, more fat stranding is also there.
can you do any other imaging to confirm or
Yes, sir.
rule out whether malignancy is there or not?
Yes, sir. Endoscopic ultrasound would be with an FNA of if there is a lesion there detected in endoscopic ultrasound.
You want to add any tumor markers?
CA19 blood investigation, yes, sir.
Can you
CA19
please
level.
tell the tumor marker and endoscopic ultrasound finding, please?
Meanwhile, can you tell what is the incidence of malignancy in this scenario?
Sir, chronic
Because I think
pancreatitis in long term has a 8 to 16 fold increased risk of transforming into malignancy. Percentage wise, various studies show over a 10-year period 2% risk and over a 20-year period 4% risk. Some studies also show over a 5-year period so 3% risk. It varies, sir. Somewhere between 3 to 5% long-term risk.
okay. So what do you want to see? Tumor marker.
CA99 is normal.
EUS is that?
So this,
US,
please note the timing because
okay.
please note the timing also because ultrasound and this EUS is of same duration. So you need to
Why? Yeah. Yeah, Vaibhav, please. Yeah.
please because the timing is very important in acute chronic pancreatitis when the CT was done, when the ultrasound was done, because the definition, because you were in between saying inflammatory head mass, then collection, then world of necrosis. So things are different according to the timing. Is it
According to timing, yes, sir.
acute collection? Is it a necrotic collection or is it a world of necrosis? So you need to keep on the timing when was the investigation done and when the patient was symptomatic. According to you need to keep your diagnosis. So now read and then give the impression.
Sir, endoscopic ultrasound is suggestive of chronic ulcerative pancreatitis with the inflammatory mass, sir, inflammatory head mass. It is heteroechoic collection with solid cystic areas. They are not able to clearly find features suggestive of more of
Karthik,
inflammatory
now
changes.
it's not exactly just Dr. Vaibhav has told you, no? After seeing the EUS, what is your diagnosis now?
Sir,
Is it
chronic
inflammatory head mass?
sir, chronic ulcerative pancreatitis is inflammatory head mass, sir.
Why you are telling? They are telling it is a collection.
Collection, no? Why do you say head mass, head mass? It's a collection.
Sir, with the collection, solid areas are also there.
What is the EUS finding in an inflammatory head mass of the pancreas? What do you expect?
Sir, it will be.
What exactly is inflammatory head mass? What is it? Is it heteroechoic?
Sir, sorry, sir, I can't understand.
Is it heteroechoic?
Echoic, okay. Sir, it is. Sir, heterogeneous, sir. It is inflammatory head mass. Hypoechoic regions may be there.
So hypo. So we are not seeing hypo here. So this terminology is very critical, no?
Okay.
In the first line, it is written, it is a heteroechoic
collection.
Okay. So
Sir,
what do you need to do now? This is a collection.
Sir,
2024.
March 2024 at the
So
time.
what do you want to do? Like what you will do with the patient?
Sir, I would like to conservatively manage the patient now, sir, with
Okay, then what next?
collection. Sir,
Anything for the collection? Sorry, what you said?
sir, the patient doesn't have any symptoms now.
So
The symptoms
what
have
do you?
subsided. He is asymptomatic.
Mhm.
Currently we conservatively manage the patient for now.
Okay, 1 month is over. You have managed the patient conservatively. There are two possibilities. Either the patient will deteriorate or patient will stabilize.
Stabilized.
So suppose the patient deteriorates, the condition is not improving. So what will you expect?
If the patient deteriorates, the condition is not improving. It can be due to complications of ongoing pancreatitis
Yeah.
or worsening of the pancreatitis.
Mm-hmm.
The collection might increase in size. It can go for infection.
Okay.
It can become an infected collection or
In that case, what will you do?
sir, if it is an infected collection and patient is worsening with high-grade fevers and tachycardia, then infected collection has to be drained. This situation, it is located in the head and uncinate. It should be amenable to endoscopic drainage likely.
Okay, if the patient is stable, like your patient, then what will you do after 1 month?
1 month. If the patient is stable after 1 month, I would like to repeat the imaging and see, sir, whether because I would like to have an option of surgical option for the patient since her pain is significant.
The
Karthik,
imaging.
CT.
you understand the question also. You want to manage the patient finally surgically?
Finally, surgically, sir.
What surgery?
Sir, this patient will require phrase procedure. I will do a phrase procedure.
So you want to do. So you want to do in the presence of that collection?
Sir, 1 month later, I would do a repeat CT and then take a call, sir.
So till that time, do you want to manage the collection or wait and watch?
Wait and watch, sir.
If it is not resolving?
If it is not resolving.
Is there a chance that it may not resolve?
There is a chance that it might not
So
resolve.
what will you do?
Sir, I would go ahead with this surgery, sir.
No, surgery, or do you have any other option?
Sir,
to drain the necrosis of collection?
endoscopic drainage can be
So you
attempted,
tell
sir.
all these options. No, that's what the question.
Okay.
Okay. Yeah, please go ahead. Yeah.
Suppose the imaging has come now after 1 month, the collection has settled, inflammation
Okay,
has regressed completely. Now the patient is with you. The pain subsided by your treatment, but it shows the same chunky calcifications in the head and intraductal calcification with the CBD narrowing. How will you proceed?
So the collection has subsided. Everything else
Yeah.
has normalized. Yeah.
Inflammation
I
has
would.
subsided.
I would
You
like
send
to
the
go ahead
patient
with.
home?
No, sir. I would like to evaluate the patient for surgical pre-op evaluation and then post the patient.
Any role of MR here?
Sir, if the collection has subsided, then in CT, the collection is subsided and only just the calcifications are there with an atrophic pancreas, then I would, the CT itself is enough, sir. MRI has a role in
When?
CCP with the MRCP. It is contrast enhanced MRI is latest is almost equivalent to CECT to look for vasculature also. But more use of MRI would be to look at the ductal anatomy and to look at the ductal disruptions more clearly. MRI with MRCP reconstruction might be helpful. And cystic lesions of pancreas, MRI it will be better to delineate the cystic lesion, sir.
So this
These are the
patient,
two-
your statement has to be clear, no? This patient where you are suspecting a
This-
collection, malignancy versus inflammatory head mass, MRI has a greater role. Okay, because the questions you are looking to diagnose it differentially, MRI can show it better. Okay, so MRI is not inferior to CT, it may be superior to CT
Yes.
in this particular situation. Okay.
Yes.
So can we invite comments from other panelists? We are hitting the time.
Yeah, I think Professor Kapoor, Professor TD, Shastri, Sikora.
Morning, Pradeep.
Morning, sir.
VK Kapoor here. So just a few points. 51-year-old female, recurrent episodes of upper abdominal pain for 7 years, loss of weight for 1 month. I would start analyzing this not by giving our diagnosis, but by saying that most probably she has a benign lesion which may have turned malignant now. And the possibilities are in the pancreas because of the history of radiation of pain to the back, and it could be chronic pancreatitis or a cystic neoplasm of the pancreas which may have turned malignant. The other experts may correct me whether there is a possibility of a biliary cystadenoma in the liver which has now turned malignant, and as was discussed, a remote possibility of a gastric ulcer which may have turned malignant, although most people feel that gastric ulcers are malignant to begin with. Now, when you have some numbers on the screen, like blood report or LFT, don't read the numbers. You analyze them, you interpret them. And there is a difference when you are seeing an imaging, there is a difference between the findings and the interpretation. And that is what Dr. Biju was again and again asking you on ultrasound. So on ultrasound, you should have said that ultrasound is suggestive of chronic pancreatitis, which is the underlying or the primary disease. There are changes to suggest acute pancreatitis. There is possibly a collection. There is evidence of biliary obstruction. There is difference between biliary obstruction and biliary stricture. Biliary obstruction in a patient with chronic pancreatitis can be because of a stricture, but it could also be inflammation because of the superimposed acute pancreatitis. It could be a small collection which is causing obstruction to the biliary tree. It could be a mass which is now causing obstruction. And also on ultrasound, when you are interpreting, you should have said that ultrasound does not show any evidence of malignancy. You said amylase lipase after ultrasound. Once an imaging has been done, it shows that there are changes of acute pancreatitis. I'm not sure if amylase lipase have any significance because even if they are normal, as it was in this case, would you say that it is not acute pancreatitis? So once you have the imaging evidence of acute pancreatitis, then probably enzymes do not have much role. Now, in the differential diagnosis, after looking at the CT scan, you should have probably said that CT shows a mass, and it could be inflammatory, it could be malignant. And when you were asked how do you differentiate, some of these questions are theoretical questions, and whenever a theoretical question is asked, you should grab the opportunity to show your knowledge. You should have said there are several ways by which we can differentiate between an inflammatory and a malignant mass in the setting of chronic pancreatitis, starting with tumor markers, MRI, especially diffusion-weighted MRI, endoscopic ultrasound, and EUS-guided FNAC, and PET scan, and then discuss each on its merits and demerits. So you should describe it completely. These were a few points which I wanted to make. So students, please send me a mail, vkkapoor.india@gmail.com. Write CP in the subject of the mail, and I'll send you the chapter on chronic pancreatitis. And one more point, sorry, that when you are not sure whether it is an inflammatory or a malignant pathology, waiting for some time and a re-evaluation, you have to emphasize that. And you could have even re-evaluated with more frequent ultrasound, because if this collection or mass, whatever it is seen on ultrasound, size has been documented, you do after 2 weeks, then you do after 4 weeks, and you would know whether it is settling or whether it is remaining the same or enlarging. And that would be a big help to know what the nature of the lesion is. Thank you.
Thank you. Biju, there are two questions in the question box. Can you?
Okay. So role of EUS guided aspiration of biopsy, possibility of group pancreatitis. So EUS guided aspiration for diagnosis, I would like to do in this patient, definitely. Group pancreatitis considering the solid cystic areas. See, at the end of the day, group pancreatitis, please understand that the entire pathophysiological process is still not completely explained. So please do not overdiagnose that entity. If you overdiagnose, we will land up in trouble. And just based upon imaging in this patient, I won't diagnose it because this is a chronic pancreatitis with a collection, walled off collection there. So no possibility of group pancreatitis here. It may be an associated finding. Can be a retention cyst when to say? I don't understand what is a retention cyst here. Others can answer. What surgery if there is a head mass with CCP? Head mass, what is the meaning of head mass to be defined? Head mass is a vague term. Is it an inflammatory mass or a malignant mass? It has to be explained. In doubt, pancreatitis. Dr. Cyst, do you want to answer what exactly is that? What is the meaning of that question? Yeah, Dr. Shastri wanted to.
Yeah, I just wanted to add one point. In this type of clinical profile, it's particularly when you're considering seriously chronic pancreatitis. In fact, that is standing out in the clinical profile itself. It's important to follow the natural history of the disease. The recent changes, they have to be given a lot of importance. How the pain is becoming resistant to the painkillers, and how frequently it is coming, and then the loss of weight. These are the crucial points which have to be given a lot of importance, and your investigation will be directed towards any recent change in chronic pancreatitis, particularly malignancy or inflammatory mass or a pseudocyst or a rupture, any of these. And definitely with this pain, all you want to rule out is an acute pancreatitis here before you embark upon surgery. Surgery is definitely an option here because of this recent change. And the imaging doesn't show that kind of acute pancreatitis. There may be a slight blurring of the pancreatic edges, some fat stranding, but intrapancreatic collection is less of a contraindication than a pancreatic necrosis, which is outside. Now, this can very well be managed by surgery, and surgery would definitely give you a chance to consider malignancy and rule out. I think that point needs emphasis. Otherwise, Karthikeyan, you are okay. You have done okay fairly well.
What surgery? There is a head mass with CP. I think the trainee wanted a malignant. If it is malignant, if it is malignant, the context changes, the diagnosis changes. The patient is a case of carcinoma head of pancreas with the chronic pancreatitis. It's not chronic pancreatitis with malignancy. It's the other way. So it is a pancreatoduodenectomy, and you can extend the anastomosis as a longitudinal pancreatitis or without that also. That is debatable, but pancreatoduodenectomy may be a best option. Dr. Sadiq sir, sir.
Can I just make 2 or 3 comments? Karthikeyan,
Yes,
I
sir.
think everyone has talked about the differential diagnosis, and I think you started on the wrong foot by having. I must say this, Pradeep, that I wonder whether the candidates know the diagnosis of the case, because I often find that the discussion is geared towards what the diagnosis is rather than a very wide discussion of possible causes. And I'm a little concerned that, if you know the diagnosis beforehand, you're bound to be very go in a narrow lane because you already know what the diagnosis is. So it was evident in the way you discussed the history of this patient. The second thing is about the radiology. Now, when you're doing a radiology evaluation, if you're looking at the plain scans, you have certain things to see. And if somebody even pushes you to comment on other things, you would say that I would want to see all the phases before I make a final commitment to what the findings or impression on CT is. So you were going to and fro on arterial phase without seeing the venous phase, and so on and so forth. So I think you should be clear that if you want to make a diagnosis on CT scan and have an impression, a complete evaluation or assessment of the scan should be done before you come to a conclusion. Also, specific findings like the manner of enhancement of the lesion on the venous phase from the arterial phase, the border of the vein, the way it is, all those findings were not specifically pointed out and discussed, because I think the possibility of malignancy in this situation cannot be ruled out. And though you mentioned that there is tumor markers are important, you never bothered to find out what the tumor markers were. That means you are just close-minded. You said, yes, tumor markers are required, but you never asked for it. You didn't emphasize the fact that you need to go further with EUS and biopsy in a patient like this before you embark on a strategy of surgery. So, what I feel is you're just focused that it is a chronic pancreatitis with collection, and that's all. You did not have a bandwidth to see wider the other possibilities which may change the way you tackle this patient in the long run. Thank you.
I think I agree, Sadiq. Actually, we made the candidate does not know the investigations, but I don't know, these people might be getting to our registrars. I'm not sure.
No, sir. No, sir. No, sir.
Yeah,
We have no access to anything actually.
Yeah, I know. We try to make it confidential, but I don't, because as I agree with Dr. Sadiq. Actually, it's a biased. You are totally biased.
I mean, not only in this case,
In the other cases as well, even in previous this thing. So I instructed people not to reveal, but I don't know.
And it's not in the candidate's interest. If I would not want to know, actually.
You are the loser. Candidates are the ones, they lose it because they don't have a broader perspective in their approach. TD?
Yes, sir. Good morning. So I agree with the last part of the discussion. And more so, when you know the diagnosis, then there are only two, three things left. How to investigate, which is obvious to everybody, and then what surgery has to be planned, that is also very obvious. So how a resident approaches to a case with the broader mind, and that shows the total approach of the resident about the particular problem. Like in this patient, deep penetrating ulcer in the pancreas can have almost same type of presentation with a little bit of difference. And then IPMN might have been discussed, which can have same type of presentation. Sometimes it's very difficult to differentiate. And the second important point, that there were two important clues that Dr. Sastry was saying when you came to chronic pancreatitis, that you had three important, the character of the pain and severity of pain change. Then there was a change in the diabetes control, and then there was a weight loss. These 3 points were pointing toward malignancy. So malignancy should have been with the chronic pancreatitis, which is a pre-malignant, pre-cancerous condition, could have been high on the card, and a proper approach to exclude that there is no malignancy in the head should have been done. That is what is this thing. And when you are saying that there is a dilatation central, and then repeatedly candidates saying that inflammatory stricture. Inflammatory is a pathological finding. You have a stricture that have a characteristic points toward benign or malignant. So just based on the dilatation little bit, and because because there is dilatation and central dilatation. Every time you are say that this is inflammatory stricture, that is probably not the correct. And then these are the three important points I wanted to convey. Thank you, sir.
Thank you, sir.
Thank you. So actually, we entertained malignancy as a possibility in this patient, and this patient for some family issues went and came back later. After can we have the report of the latest CT?
In latest CT, selection was not noted, sir. It had resolved, and just the findings.
So we were wondering whether the candidate came to know about this CT and then he talked to the benign condition. That's what I got an impression. Actually, I was surprised. We entertained the possibility of a malignancy in this patient, but now the latest image, in a matter of 1 month, has changed.
Sir, I didn't have any access to any of these.
Okay, no
Only the
problem.
case capsule.
That's okay. That's okay.
History.
Okay. Is there any more comments or this thing?
No,
or
no, sir, we can conclude.
Thank you, Biju.
Thank you, sir. Thank you.
Anand, thank you, Vaibhav, and thank you, other faculty members. Thank you very much. Thank you.